Thank you, Mr. Chairman. Ladies and gentlemen, I'd like to present our work on the stress response following laparoscopic colorectal surgery. Enhanced recovery programs originated in the 1990s and were originally envisaged for open colorectal resections. The current recommendations have largely been applied wholesale to laparoscopic colorectal surgery with little change. One of these elements is attenuation of the stress response with particular use of a thoracic epidural which is left in situ for up to 48 hours in open colorectal surgery. And this is one of the recommendations from the Association's guidelines for enhanced recovery and also one of the ERAS consensus review group's recommendations. And as such, there's a large body of anaesthetic opinion that has applied this wholesale to laparoscopic colorectal surgery. However, there's been a recent randomized clinical trial that's shown that the use of a thoracic epidural compared to a spinal analgesia or morphine PCA can produce significantly increased length of stays in laparoscopic colorectal surgery, and as such, we no longer use a thoracic epidural in our unit. The thoracic epidural has been reported to attenuate the perioperative neuroendocrine stress response, but has little effect on the inflammatory and immune response postoperatively. However, there's no supporting evidence in the literature for laparoscopic colorectal surgery. The postoperative stress response can be divided into three elements. There's an endocrine element, metabolic element, and an inflammatory and immune element. With that, we aim to ascertain the exact nature of the stress response following laparoscopic colorectal surgery. In particular, we wanted to quantify and compare the effect of spinal or morphine PCA in laparoscopic colorectal surgery. We conducted a randomized clinical trial between 2010 and 2011. The primary outcome of this study was to investigate aspects of the stress response following laparoscopic colorectal surgery. In order to be eligible for the trial, patients had to undergo a laparoscopic colonic or rectal resection, were excluded if they had a stoma formed, were converted to an open operation, diabetic or on steroids. Power calculations were performed on a pilot study conducted at the same unit, and a sample size of 120 was required to see a difference in insulin, cortisol, or IL-6. Patients were randomized to 4 equal groups. They either received a spinal or a morphine PCA as their primary postoperative analgesia. They also either received 6% volulite, a colloid, or Hartmann's, a crystalloid, which was given alongside the esophageal Doppler monitor, and this was one of the secondary outcomes of the study. Patients were within an established enhanced recovery program which had been running since 2006. No patients received oral bowel preparation. All patients received preoperative oral carbohydrate loading, and goal-directed fluid therapy guided perioperative fluid optimization. Venous blood was drawn on the morning of surgery prior to being anaesthetized. Further samples were taken at 3, 6, 12, 24, and 48 hours following skin incision. These samples were analyzed for insulin, glucose, and cortisol, and a range of pro- and anti-inflammatory cytokines. 143 patients were approached, 133 were randomized. There were 13 exclusions, leaving 120 split evenly between 4 groups. There was no interaction for fluid, and data is presented here as combined analgesia modality groups. There was no significant difference in patient characteristics between those patients receiving a spinal or those patients receiving a morphine PCA. Looking at the blood analysis, the serum cortisol and glucose were significantly reduced at 3 hours in those patients receiving a spinal analgesia compared to a morphine PCA. But there was no further significant difference between patients receiving a spinal or PCA at any of the further time intervals for any of the other parameters measured. Here we can see the median and interquartile range for the cortisol values at the various postoperative intervals in the postoperative period. As we can see, at 3 hours, patients receiving a spinal analgesia had a significantly reduced value compared to patients receiving a morphine PCA. But by the time the spinal afferent blockade had worn off at 6 hours, this had returned to show no significant difference between the groups. However, it's worth noting that at 12 hours, the purple box, that levels had returned towards baseline. Here we can see the median glucose values in the postoperative period. There was a slight hyperglycemia in the postoperative period, and the spinal patients had a significantly reduced level compared to the PCA patients at 3 hours, albeit only 0.5 millimole per litre. There was a suppression in insulin in the postoperative period, as one would expect, but there was no significant difference between the groups, and by 24 hours this had returned towards baseline. IL-6, which represents the post-operative inflammatory response, showed a rise post-operatively, but by 48 hours this was returning towards normal, and there was no significant difference between either analgesia modality. Looking at the complications, there was no significant difference in the distribution of complications using the Clavin-Dindo classification between the groups, but the number of patients experiencing a complication in the morphine PCA group was significantly higher, and this was by and large in part due to 1 in 5 patients experiencing a post-operative ileus. As we can see, that the patients receiving a morphine PCA, as you would probably expect, used a significantly higher level of morphine in the post-operative period compared to the opiate-sparing spinal group. Also of note, the pain scores at rest at the various intervals up to 48 hours following surgery were significantly reduced in those patients receiving a spinal compared to a morphine PCA. However, by the 12, 24 and 48 hours, the differences are fairly marginal. There was no significant difference in length of stay between patients receiving a spinal or a morphine PCA. The median length of stay across the study was 2.5 days, although there is a long tail on the morphine PCA patients. So in conclusion, Mr. Chairman, ladies and gentlemen, as expected, there is an endocrine, metabolic and inflammatory stress response increase following laparoscopic colorectal surgery. However, by 24 to 48 hours, this response has mostly abated. Transient reductions in cortisol and glucose occurred just so long as the afferent block is still working in the spinal group. Enhanced recovery programs may attenuate the stress response further, which may account for the similarities in the measured response between the spinal and the PCA patients. This truncated response in laparoscopic colorectal surgery within an enhanced recovery program is associated with a length of stay of 2 to 3 days. And we feel that focusing on attenuation of this stress response in the choice of post-operative analgesia in laparoscopic colorectal surgery appears irrelevant.